Hello everybody, I'm Dr. Neediya Muhamad Ashraf, second year postgraduate from Yenepoya Medical College, Mangalore. Today I'll be talking about an overview of keratorefractive surgery, patient evaluation, selection and decision making in refractive surgery. So I'll be talking about how to classify keratorefractive surgery, to enumerate the indications for keratorefractive surgery, describe the underlying principles, understand the evaluation of patients, and describe the criteria for selecting patients for refractive surgery. The first instance of refractive surgery was recorded in 1948. But Jose Ignacio Barraquer is known as the father of keratorefractive surgery. He is known for the introduction of Keratomileusis, and he is also known for the discovery of two instruments, that is cryolathe and microkeraton, which is used in LASEK. Corneal refractive surgeries are divided into four: incisional, excimer laser assisted, non-laser lamellar and collagen shrinkage. Coming to incisional keratorefractive surgery, the main principle is that when you make an incision on the cornea, there is local flattening in that area. They are divided into two: radial incision and tangential incision. In radial incision, there is flattening in the meridian of the incision and 90 degrees away. As you can see in the picture, imagine this as a cornea. When radial incisions are made, because of the tissue separation, there is flattening in the center part of the cornea. Now, imagine this is the cornea and you make an incision here, okay, radial incision. Because of the separation of the fibers here, there will be a flattening in this meridian, that is the meridian of the incision, and flattening 90 degrees away. In tangential incision, there is flattening in the meridian of the incision and steepening 90 degrees away. This is called coupling. Coming to the concept of coupling, imagine this is a cornea. This is the principal axis, the steepest axis. Now two incisions are made without tissue loss. Because of this, because of the separation of the fibers, there is flattening in that meridian, and because of the coupling forces that act perpendicularly, there is a central steepening in the 90 degree meridian. Now consider this as a cornea. And this is the steep axis. And consider this as the flatter axis. Now, when you make two incisions, that is incision on the steeper axis, because of the separation of the fibers here, there is flattening in this meridian, and because of the perpendicular coupling forces, there is steepening in the previously flatter meridian. The coupling ratio is a relationship between flattening of the incised axis and steepening of the opposite axis. For arcuate incisions which are parallel to the limbus, this ratio is nearly 1, which indicates that the overall spherical equivalent refractive error remains unchanged. Incisions are divided into three: radial keratotomy, which is done in myopia; astigmatic keratotomy, which are again divided into arcuate, limbal relaxing incision and Roy's procedure; hexagonal keratotomy, which is done in hypermetropia. Coming to radial keratotomy, here, as I had explained before, that there is flattening in the meridian of the incision and 90 degrees away. This is a video taken from AAO. In this, radial incisions are made, and there is, in cross section you can see that there is flattening in the center part of the cornea. So what happens is that the refractive power of the cornea is being shifted from the center part of the cornea to the peripheral part. Coming to astigmatic keratotomy, here there is a flattening in the meridian of the incision and steepening 90 degrees away. This video shows that here two incisions are made and because of the effect of the separation of the tissue, there is flattening in the meridian and steepening in 90-degree away. There are 3 types. In limbal relaxing incisions, the coupling ratio is 1, so there is no need to change the lens power. In arcuate and tangential, since they are more closer to the center of the cornea, there is an increased chance of inducing irregular astigmatism. Have you ever been to a Thanksgiving dinner? So next time when you go for a Thanksgiving dinner, this story should always come to your mind. In 1981, there was a scientist called Srinivasan. So this Srinivasan, he discovered that ultraviolet rays could be used to etch perfect designs on polymers. So one day he got the idea of using this excimer laser on Thanksgiving dinner turkey. And he found out that it could etch perfect design on the organic tissue also. So later, in 1983, an ophthalmologist called Stephen Trockel came, visited Srinivasan, and they together came up with the idea of using excimer laser on human corneas. This experiment led to the groundbreaking LASIK eye surgery discovery. What is excimer laser? Excimer means excited dimer. They comprise of 2 atoms, argon and fluoride. Now when these 2 atoms separate, they release a large amount of photon energy of wavelength 193 nanometer. Now human cornea has an extremely high absorption coefficient at 193 nanometer. So there is minimal damage to the adjacent tissue during this process of photoablation. The peptide bond of corneal collagen molecules is formed by carbon-carbon and carbon-nitrogen bond. So when one photon hits a cornea, the energy is enough to break the molecular fragments. These molecular fragments are ejected at high speed. A single impact can remove 0.25 micrometer of the cornea. Now coming to pulse. These energy that are released are in the form of pulses. What is a pulse? Pulse is a single burst of laser energy produced in a very short interval. They have few properties. First is pulse duration. The duration is between 4 to 25 nanosecond. Shorter pulses, they reduce the thermal effect on adjacent tissue. This is why excimer laser is called a cold laser. The frequency range is from 10 to 1000 Hz. High frequency may increase the thermal effect. So the optimal frequency is between 10 to 50. Pulse energy, it is between 10 to 25 millijoules per pulse. Energy, this energy variation can be between 10%. During a typical procedure with 50 pulses, the total depth variation is about 0.1%, which is generally negligible. The fluence or energy density or the amount of energy that is required to ablate a unit area. It is about 50 millijoules per centimeter square. Tissue ablation increases non-linearly up to 600 millijoules. After that, it doesn't increase the tissue ablation depth at all. Rate of ablation is between 0.25 to 0.6 micrometers per impact. Different layers of the cornea gets ablated at different rate. Like the epithelium ablates faster. Stroma is 30% faster than Bowman's layer. Corneal scars ablate slowly. Dehydration can affect the rate. It can there might be an under and over correction by about 10 to 15%. Now why are these parameters important? These are important for optimizing the photoablation process and also reducing the adverse effects. Excimer laser assisted surgeries are divided into 2, surface ablation and lamellar procedures. Surface ablation includes photorefractive keratectomy, laser-assisted subepithelial keratomileusis, epipolis laser in situ keratomileusis, and lamellar procedures include laser-assisted in situ keratomileusis, that is a LASEK, Femto-LASIK and refractive lenticule, which includes relax and smile. In surface ablation, first we abrade the epithelium of the cornea and then we use excimer laser to ablate the rest of the layers of the cornea. And in LASIK and Femto-LASIK, it requires creation of a flap. So 90% of complications that happen during a keratorefractive surgery is because of a flap. If you can avoid flap or if a surgery does not require creation of a flap, so much of the complications can be reduced. In surface ablation is mainly done in cases of low to moderate myopia or astigmatic error. They are also preferred method when there is corneal thinning or steep and flat corneas. Now in corneal thinning, the thickness of the cornea is reduced, reduced. So in such cases, it is better not to go for a creation of a flap. In steep and flat corneas, there is always a risk of buttonholing and creation of free flap. And in cases of patients who work in armed forces or are into contact sports or are into vocational activities which predispose to ocular trauma, we do not prefer surgeries where flap creation is needed because they have an increased chance of dislocation of their flaps later in life. Coming to PRK surgery, in this, the first step is to apply topical anesthetic. Then the epithelium is abraded using a meroceal sponge. Once it is done, the rest of the layers of the cornea is ablated using excimer laser up to the required depth. Once excimer laser does its job, we apply mitomycin C, 0.02% of mitomycin C, so that there is no post-procedural haze. Then we place punctal plugs and bandage contact lenses. Coming to LASEK surgical technique, the difference here is that you do not abrade the cornea using a meroceal sponge, but instead you apply 18% of dilute ethanol. First, you apply 18% dilute ethanol, and then using Vanna scissor, you separate the epithelium as a single sheet. Later, you ablate the rest of the layers of the cornea using excimer laser. Once excimer laser does its job, this epithelial sheet is placed back, and then BCL is placed over it. Coming to epi-LASIK. In epi-LASIK, an instrument called epikeratome is used to separate epithelium. As you can see in the image, first the cornea is marked and a suction ring is placed with the epikeratome. This epikeratome has a blade which passes over the cornea. Once it reaches the opposite edge, epithelium gets separated as a single sheet. This sheet is raised, and the rest of the layers of the cornea is ablated using excimer laser. After excimer laser's job is done, you place this epithelial sheet back and place a BCL over it. Now the steps in epi-LASIK and LASIK are almost the same, but the difference is that in epi-LASIK you separate the epithelium using an instrument called an epikeratome, while in LASIK you use an instrument called the microkeratome. This is a patient in education video taken from AAO. As you can see, first we place a suction ring. This suction ring increases intraocular pressure to about 60 mm Hg. Once adequate intraocular pressure is attained, we place a microkeratome blade over it. This microkeratome blade passes through the cornea, creating a flap. This flap consists of epithelium, Bowman's membrane, and a part of stroma. Once the flap is created, the instruments are removed, and then excimer laser is used to ablate rest of the layers of the cornea. Once excimer laser does the job, this flap is placed back and a BCL is placed over it. Coming to Femto-LASIK. The difference in Femto-LASIK is that here we do not use any instruments to create a flap, but we use femtosecond laser to create a flap. As you can see, a femtosecond laser is used to create a flap. Femtosecond laser is a solid state laser with 1053 nanometer, and the mechanism is photodisruption. Once a flap is raised, excimer laser is used to ablate the rest of the layers of the cornea. Now there are two lasers which are used in Femto-LASIK: femtosecond laser and excimer laser. Once excimer does its job, the flap is placed back and BCL is placed over it. Now coming to small incisional lenticule extraction, here the difference is that you do not create a flap, while you create an intrastromal lenticule using a femtosecond laser. As you can see in the video, you use a femtosecond laser to create an intrastromal lenticule. Now femtosecond laser, once a lenticule is made, the same femtosecond laser is used to create an incision at one part, and then this lenticule is removed and discarded. Now smile procedures are right now done for myopia and astigmatism. Since this procedure does not require creation of a flap related complications are not present after this surgery. Coming to non-laser lamellar, they are of three types: epikeratoplasty, keratomileusis and intrastromal corneal ring segments. Coming to non-laser lamellar, they are of three types, that is epikeratoplasty, keratomileusis and intrastromal corneal ring segments. Now epikeratoplasty and keratomileusis are both obsolete procedures now. We only do intrastromal corneal ring segments now. In intrastromal ring segments, as you can see in the picture, there are two ring segments which are made of hydrocele or polysulfate. They are placed inside a tunnel made inside the stroma, and it acts by displacing the lamellar bundles and shortening the corneal arc length. This is used in keratoconus cases because it gives an additional support to the weak cornea also. Collagen shrinkage, these procedures are not done now, but they are divided into two: laser thermokeratoplasty, which uses thermal energy, and conductive keratoplasty, which uses radiofrequency energy. The mechanism of action is by shrinking the collagen, so the central part of the cornea steepens. This is a proposed classification of keratorefractive surgical procedure. Coming to patient evaluation and selection in refractive surgery. Now a patient that we select should be more than 18 years of age, should have a stable refractive error for 1 to 2 years. By stable refractive error, I mean that the change in the refractive error should not be more than half a diopter for 1 to 2 years. Now if a patient is a contact lens wearer, they have to stop contact lens wearing because they have a chance of developing corneal warpage. So if patient uses soft contact lenses, they have to stop using it for 2 weeks, and for rigid and hard contact lenses, they have to stop for a longer period. Degree of correction, for myopia it is up to -10 diopter, and for hyperopia it is up to +4 diopter. Now patient expectation. If a patient's best corrected visual acuity is 6/12 using spectacles or contacts, then you should explain to the patient that their BCVA, best corrected visual acuity, would still be 6/12 after a refractive procedure. That is, they cannot expect a 6/6 correction in such patients. Second, if a patient belongs to a presbyopic age group, you should always explain about the method of monovision. That is, one eye can be corrected for distance and the other eye can be corrected for near. When you choose a patient, you should consider the patient's occupations and hobbies. Like if a patient works in armed force or is into contact sports, they have a risk of flap dislocation later in life. So you should avoid flap creation procedures in these patients. Uncontrolled diabetes is an absolute contraindication because they have unstable refraction and have poor wound healing. Now if a patient has HbA1c less than 7.9%, has normal corneal sensation and have no signs of diabetic retinopathy, these patients might be considered. Pregnancy can cause temporary changes in the refractive error, corneal curvature and tear film quality. Additionally, there is a risk of pregnancy-induced keratosis also. So the current recommended time for undergoing keratorefractive surgery is 3 to 6 months post cessation of lactation. Uncontrolled collagen vascular disease is an absolute contraindication because they will have higher chances of corneal melt and irregular healing. Additionally, patients with Sjogren's disease and thyroid associated eye disease have irregular tear film and dry eyes. Theoretically, patients with dermatological keloid might develop keloid in the eyes also, but there are no reported cases, so now surgeons don't really consider this as a contraindication. HIV. There is a theoretical risk of HIV transmission through the plumes that are created during excimer laser. So it is better for the surgeon to take additional precautions in these patients. When you select a patient, these patients must undergo appropriate therapy, should have adequate CD4 counts because they have an increased risk of infectious complications. Extra precautions has to be taken by the surgeon when you are dealing with a patient who takes amiodarone, isotretinoin or sumatriptan. Amiodarone can cause deposits within the cornea. Isotretinoin, which is usually used for acne, can cause dry eyes, and sumatriptan has theoretically proven to reduce the healing process. Do not take up patients who are a case of corneal dystrophy, especially in fused dystrophy because they have corneal decompensation, and due to the subclinical edema, they have a potential risk of misestimation of corneal thickness. Corneal ectasia patients are an absolute contraindication. So if you get a patient with keratoconus or pellucid marginal degeneration, you should never take up these patients. Dry eyes should always be treated prior to the procedure. You can start them on artificial tears or punctal plex. You can also start them on cyclosporin A, 0.05% of cyclosporin A eye drops. Herpes reactivation is a well-known complication of keratorefractive surgery. So when you take up a patient who is a non-case, they should be an inactive case for at least 1 year, should have normal corneal sensitivities and parameters, and you should always start them on oral and topical antivirals to minimize the risk of reactivation. You should always explain to the patient that they have to be very conscious because if they develop a reactivation, there is a risk of severe corneal scarring. Uncontrolled intraocular pressure is an absolute contraindication. If they are controlled, they may be taken up for the surgery. Post-operatively, we start the patients on steroids. So you should keep in mind that patients who have steroid responders might again have an increase in IOP due to the post-op medications. And in such patients, if you go for a LASEK procedure or any procedure which requires flap creation, as I had mentioned before, it requires increasing the intraocular pressure up to 60 mm Hg. So this will worsen the health of the optic nerve also. So in such patients, you have to better go for a surface ablation procedure such as PRK. In monoocular patients, it is discouraged to take such patients until and unless the amblyopic eye is functional. Coming to examination, visual acuity recording of the patient should be done. Uncorrected and corrected visual acuity should be checked using Snellen's notation. Initial manifest refraction should be done. Contrast sensitivity should be checked with appropriate correction. Cycloplegic refraction is essential to detect any latent ciliary hypertonus. Keratometry and corneal topography should be done. Coming to corneal topography, it is required to map the corneal surface. Now they use two technologies, that is Placidodisc and Pentacam. In Pentacam, it uses a rotating streamflex camera which provides a 3D image of the cornea, that is topography, pegmetry and anterior chamber depth. So why is this important? Now if you have a patient of keratoconus, in such cases you can see the thinning in the central part of the cornea and thickening in the normal thickness in the peripheries. So in such patients you cannot go for any flap based procedures. Pupil examination is a very important part because people who have large pupils might have post-operative halos, glare and increased wavefront aberration. So now the current recommendation is to always discuss with the patient about the potential risk, especially if the pupil diameter is more than 6.5 millimeter. After the procedure, you should always start the patient on brimonidine tartarate 0.5% lifelong. Slit lamp examination is required to check for the tear film and lid margin health for blepharitis, mebomitis. In corneal, health should be checked for to look for any developmental abnormalities. Descemet's membrane should be checked for haze or guttate. And in patients who have cataract, they are not an ideal patient for refractive surgery, keratorefractive surgery. Complete fundus examination has to be done before a keratorefractive surgery. And if you find out any abnormality like a tear or retinal detachment or signs of diabetic retinopathy, you should always treat this retinal pathology first, wait for 1 month, make sure that they do not require any more retinal procedures, and then only proceed with the keratorefractive surgery. Tonometry examination is to be done to find out if they have an intraocular hypertension. Another thing is that post keratorefractive surgery, there is thinning of cornea. So the tonometry values that you get post refractive surgery will always be an underestimation of the actual value. Pachymetry, it is required to measure the corneal thickness to calculate the residual stromal bed thickness. And intraoperatively, pachymetry is used to find out if there are any unexpected thick flaps. Anterior chamber depth is more important in case of phakic IOL implantation. Ocular dominance testing. In this, you ask the patient to look at the largest Snellen chart alphabet, and then you ask them to make an aperture using their fingers and move it towards a patient. And patient is asked through which eye he or she can see the alphabet. So if the patient tells you right or left eye, that eye is considered to be the dominant eye, and that eye is taken up for the procedure if the patient doesn't have any preference. But if the patient has any preference for an eye, you go according to the patient's wish. Wavefront testing has to be done because it always gives a superior result to conventional therapy. Now patients will have lower order and higher order aberrations. Now post keratorefractive surgery, the lower order aberrations would reduce, but there might be an increase in the higher order aberration which can reduce a patient satisfaction. So if you go with a wavefront guided or wavefront optimized treatment, you can at least minimize the increase in the spherical aberration. Coming to the flow chart of how you deal with a patient once a patient comes to the OPD. First, you always have to do a full ocular examination which includes vision, slit lamp, dry eye evaluation, binocularity, refraction, fundus examination. Then you check for the motility. If there is any abnormality in the motility, you go for further investigation accordingly. If the motility is normal, you go for dry refraction, cycloplegic refraction, and keratometry. If the keratometry readings and the refraction values do not agree to each other, you ask the patient to go back and come for a repeat examination on a later date. If these values agree, then you go for corneal topography. And in topography, if you find any abnormal shape, you ask the patient if they are a contact lens wearer or not. If they are a contact lens wearer, you'll have to ask them to stop wearing contact lenses. If the patient is not a contact lens wearer, you have to check for other pathologies such as keratoconus. Now, if corneal topography shows normal result, you go for wavefront aberrometry, pupillometry, and pachymetry. You discuss the benefit and risks to the patients, and then you schedule for a procedure. Coming to decision making. This is an FDA approved range for correction of refractive error. In cornea based procedures such as LASEK, you can correct up to -10 diopter sphere to +10 diopter sphere and 4 diopter cylinder. In PRK, it is between -2 ds to +4 dioptic sphere and up to 4 diopter cylinder. In SMILE procedure, it is only done in myopic cases, so it's only till -10 diopter sphere and up to 3 diopter cylinder. But in phakic IOL lens-based procedure, you can correct in myopia from -3 diopter sphere to -20, hyperopia from +3 to +10, and up to 6 diopter cylinder. A short note on the lens-based procedure, there are mainly two procedures: phakic intraocular lens implantation and refractive lens exchange. In phakic intraocular lens implantation, you keep an intraocular lens over the crystalline lens. While in refractive lens exchange, you exchange the crystalline lens in the eye for an intraocular lens. The difference in the inclusion criteria here is that the age should be more than 21 years of age, and they should have a normal corneal endothelial cell count of more than 23,000. Now this is an overall summary of how you deal with a patient once patient comes to the OPD. If a patient comes for a refractive surgery, you check if the patient is above 18 years of age, has stable refraction and no contraindication. If these criteria are not met, you ask the patient to wait and watch. If these criteria are met, you take a detailed history, examination, pachymetry, corneal topography, anterior chamber depth and specular counter. Then you look for certain criteria, that is CCT, central corneal thickness more than 417 micron, RSBT, that is residual stromal bed more than 250 micron, PTA less than 40, normal corneal topography, Kmax less than 47, posterior elevation less than 15, and normal Berlin-Ambrosia enhanced ectasia display. If these criteria are met, you take up the patient for a corneal refractive surgery. Now, if these criteria are not met, you go for a lens-based procedure. Here, if the PMT is less than 18 DS, it's theoretically less than 18, but above 18 are also being taken up. And if the endo-ACD, anterior chamber depth, is more than 3 mm, you can consider the patient for an Indian lens. And if it is 2.8 mm and above, you can take up the patient for collamer or collagen lenses. Now, if these two criteria are met, you take up the patient for phakic IOL implantation. Now, if they are not met and if the patient is above 40 years of age with a loss of accommodation, you can take up the patient for refractive lens exchange. Or you can take up the patient for a bioptics. Bioptics is where both lens-based and corneal refractive surgery can be done together. These are my references. Thank you.